Allogeneic transplantation offers cure for patients with AML, particularly those who carry a high-risk disease. Now, while we have a decade-long analysis showing that we have done pretty well over the last few decades and years with decreasing non-relapse mortality, GVHD, and infections, relapse has gone up. So biologically, relapse reduction is a critical unmet need in transplant setting. All prior studies that have been conducted either predated the contemporary transplant practice or were single-centered or underpowered. With this in mind, we wanted to conduct the study. We hypothesized that allogeneic transplantation, when performed for older adults with AML, with a younger match unrelated donor as compared to older match sibling donor, confers superior outcomes. In terms of methods, we used CIBMTR database. We had strict inclusion-exclusion criteria. We defined older match sibling donor as a donor who was either 50 years of age or older, and younger match unrelated donor who was either 35 or younger. Now, results-wise, we obviously included standard GVHD prophylaxis regimen, excluding post-transplant cyclophosphamide and any other combination of PDCY-based GVHD prophylaxis regimens. The results showed that out of more than 4,700 patients, there was significant relapse reduction with younger MUDs as compared to older MSDs. That did come at a cost of slightly higher non-relapse mortality with younger MUDs as compared to older MSDs in the earlier years, from 2011 through 2015. But in the more recent years, from 2016 through 2018, that NRM at disadvantage vanished. In a multivariate analysis, 5-year adjusted cumulative incidence of relapse was also lower with younger match unrelated donors as compared to older match sibling donors. Really, in the earlier years, again, the cumulative incidence, 5-year cumulative incidence of non-relapse mortality was higher with younger MUDs, and that disadvantage vanished in the recent years at 5 years. There was, in multivariate analysis, while there was no impact on overall survival, there was a signal in disease-free survival. Particularly, there was a 5-year cumulative, there was a 5-year adjusted DFS, disease leukemia-free survival benefit with younger MUDs as compared to older MSDs in patients with acute myeloid leukemia. Based on these registry-based analysis results, our group concludes that moving forward, when we have both donor types available for patients, younger match unrelated donor should be the preferred donor for transplant center and practitioners. And the way curves divorce each other at 6 months mark, relapse curves and disease-free survival curves, really signal that it's not an impact of conditioning-related effect. It's rather a GVL effect, graft versus leukemia effect, which is driven by donor immune repertoire, decreased clonal hematopoiesis of indeterminate potential, and really an impact which is driven by a donor. Hence, we do think this is a hypothesis generating and a potentially practice changing study.